Health and Family Services Committee. Attendance,
Mrs. Geiger.
here.
Ms. Vetter.
Here.
Mr. Ruiz.
Here.
Mr. Steingart. Mrs. Labuda.
Here.
Okay, good morning, everyone. Thank you for coming. We're going to start off with the ACC update from Debbie, our administrator.
I'm really pleased to be able to say that the renovations are done and the units are open. So we now have a short-term care rehab unit which has 10 private rooms that have all been remodeled, plus a number of double rooms as well. The therapies department has doubled in size. It's bright, spacious, it's a wonderful environment for somebody to come in and get the therapy they need so they can return back home. What we had been calling the dementia care or the Alzheimer's care unit, the name of that unit really is going to be the memory care unit, because we really are going to be servicing people outside of and beyond Alzheimer's, but could have a dementia or another issue that impacts the memory. That unit is open as well. We went through a lot of work to get the internal transfers done, working with family council, residents, family members, to be able to work to ensure resident rights are protected as we make various moves within the building. The units reflect the warmth of our staff. The bricks and mortars did a wonderful job, and I thank everybody on the team and the legislature who made all of it possible with the funding of the grant. But it's really the staff that actually bring forward the care to the residents. So when you come in to our facility, it is spacious, it is bright, it has positive staff members within it. We also have a lovely lake view, which somebody so nicely mentioned to me. Sometimes we forget that we overlook a beautiful lake. We're looking at a ribbon cutting ceremony perhaps the week of May 19th. I've been in contact with the county manager's office to be able to start working on dates and to plan it appropriately. The last time that I came, we had just finished with our Department of Health survey. We did receive the official results from our Department of Health survey, and the health component of it, it's two components. The health component of our survey was deficiency free, so I'm thrilled. We had a few minor issues in terms of what's called the life safety. It's two different sections of a survey. It was an amazing survey, so I'm very, very proud of the team. And like with anything else, you always just keep it moving because we never can get too comfortable with what we do when we're in the business of healthcare. We are also in the process of working on a number of quality initiatives. So there's a lot going on at the nursing home. We're looking forward to the ribbon cutting and for filling up our units. Questions?
Are you advertising?
We have not advertised yet. We're hoping the ribbon cutting will be our kickoff for the advertising.
And I just want to mention that since Priscilla is here. Priscilla?
Right over here.
Oh. 5 or 6 years ago, the county legislator, some of my colleagues then were thinking about privatizing the facility. And if it wasn't for Priscilla and the group, our seniors coming forward, they persuaded us to keep the facility, even though it costs the taxpayers money, but I think it's something we should keep. And now with the grant money, it's obvious that we're going to continue to keep the facility, but it's just something that if you have grant money and we all work together, now we have a new unit, we can save that facility because it is for our constituents. And I want to actually thank Priscilla because she was behind the scenes and pushing the scenes. Get out there, get to the legislators and tell them we're not going to sell that, we're not going to privatize, we're going to keep it. So, Priscilla, thank you for your help, say.
Thank you to the legislature and to Debbie, a wonderful new leader for our community.
Debbie, I just wanted to remark too, I see that the census is up in the daycare portion of it, the occupancy. so I'm sure that's gonna reflect in revenue as well.
Yes, and a lot of internal work is being done right now, in terms of staff education, documentation, planning strategically to take what we have and move it to the next level in terms of capturing the services we provide so that we are able to recoup the reimbursement. The care is there. It is a matter of being able to have that staff trained in terms of things like documentation, so that when the numbers are all coded and you have the bills go out, you're billing for the level of services you provided, to the highest opportunity. So we're doing an awful lot of initiatives, both on the quality component, and my basic philosophy is through quality of care, we will see the improvement in revenue because the base is quality. So it's the quality initiatives that lead to increased revenue, and I am looking forward to having the opportunity to have the time to be able to take these plans to fruition.
So you have added new training to do that?
Oh, yes,
Good.
absolutely.
And the other question I had, there was a marketing component to it, there was staff working on that piece?
Yes,
So-
we have a position that had been approved, it was, the title is a marketing outreach coordinator. We have had some challenges with the qualifications, that position requires through the civil service system, so that it looks like we may have to revamp or go with another title, which I understand involves another legislative process with the committees, et cetera, for approval, so that's been a
You're
little bit.
working on that?
Yes.
Okay. Maura?
Yeah, can you clarify, because when the wing was closed at the beginning of Grant, there were a certain number of nurses that had to be, let go, because the numbers weren't there for that particular wing. So, once you get back to your full occupancy and you're, back to exactly where you wanna be, does that mean that the numbers come back, or the numbers of the staff also, change? Do you know?
The numbers come back in terms of.
The nurses that were let go, are they coming back, or how did that all
There
shake
have
out?
been, as we had prepared for the unit to open, because it's a ramp-up period, individuals that had, been laid off, had been called back to see if they were interested in returning. And we're at the point now of really studying deeply, our staffing ratios, et cetera,
Okay, so we don't know yet. Okay, thanks.
Thank you. Are there any other questions for Debbie? Okay, foster care quarterly report, Commissioner Parker.
I just have a handout out of press. Sorry it wasn't available earlier. So I think last year the legislature had asked us to start providing a quarterly, and it's too small for Cora, right?
Well, my glasses, I have to get a new prescription.
So what we have, what you have is, we have the first quarter of 2014, and then we just kept, and we'll continue to do it as a rolling report per quarter, but there's a basis for comparison. The first column has, the first half of 2013, and then the third and fourth quarters of 13, and the first quarter of 14. I'm still not sure if this is the report that you want, if you want more specificity as to the different levels of care, or some glossary that may explain these bureaucratic categories that we have listed. But this is consistent with budget lines, and Mary Marino put the document together.
Well, if we're talking about, foster care costs in, specifically, can you just?
For children who are in foster care,
Right,
that category, if you go about halfway down to maintenance, regular foster care,
Where do you see that?
Right there. First one on the sheet.
Second column,
Okay.
the second,
If you go under foster care costs to the right-hand side of the page for 2014, and then you go down 7 lines, maintenance, regular foster care.
so the 726 versus the 1093.
But that's a
Yeah.
different time period, right?
Yeah, one's for 3 months, one's for 6.
We're only up to March on this one.
So it looks like, you know, it's a large number and, you know, my advocacy, and, you know, we've had lots of discussions about it, is to try to, look at our numbers in institutions, cause that's a cost for contracts, right? And to try to transition, kids and keep them more local in Sullivan County, and I know it involves, you know, the courts and a lot of pieces. But if we were to step up our efforts to recruit foster homes, because I think, in conversations that I've had with, you know, the court, staff, is that, you know, we lack the number of foster homes, because I think the last number I had was 19 in county. Would it be possible to look into, or just kind of start a conversation on maybe hiring or filling a vacancy or something for a marketing person to work within foster care with staff? And to do things like
At the beginning of the year.
school outreach, you did?
We had the retirement of our home finder, a senior caseworker in foster care. Upon her retirement and, you know, permission to fill, which that was all timely granted, we then did promote a caseworker to a senior caseworker who
Okay.
now serves as that home finder for the agency.
So what's the title of that?
It's a senior caseworker title, but his duties are the home finding, the recruitment, retention, licensing, recertification of the
Well, I'm talking
foster
more like
homes.
a community outreach, because, being that I am a certified foster home, and I have discussions with, you know, some of the staff, and what can we do to, you know, recruit. They felt it was more like a community outreach. If you listen to some of the radio, PSAs, public service announcements from like the National Foster Care Advocacy Group, or to do something like that in media and maybe in the schools, to maybe even attend events with a banner. You know, I know they do that in other counties, to try and present, you know, the process to, you know, the general public, to try to get people to sign on.
And the private providers, part of this number for foster care would be the maintenance made to, the majority of our foster kids are with private foster care providers.
How many is that?
Abbott Houses, the Children's Home of Wyoming Conference. So they're with private foster care licensed foster care providers. The private agencies, with the way the state reimburses, can hire that marketing person, can have that kind of budget. They advertise on the radio, they put signs on buses, they are able to recruit probably a little more competitively than a public entity can. But we have the one person, Michael, who is assigned to home finding. Michael is learning the ropes, and, you know, there is an effort. I think the media can always help us, that we are in desperate need of foster homes for kids who are part of a sibling group, and then also for teenagers. Now, it's a little more of a sell to talk to someone to take a teenager into their home because of some of the issues presented, but sibling groups, folks who will take, you know, a sibling group of 2 or 3, so that we don't have to separate the siblings when they are removed from the parents' home. That's always helpful, but I mean, we'll definitely see an increase in local folks who the agency licenses for foster care, and less of a reliance upon the private providers. That's what we would like to do.
So do you know the number right now of children in the homes as a whole?
There
'Cause I think it
are,
was about about 55 or 60 last night.
Right, the numbers are still, depending on, certain court filings, et cetera, they just say there are 92 children in the agency's custody, and the breakdown of those would be more than half of those children are with private providers, either in an institution or in another agency's foster home or group home. So probably 40 children are locally in Sullivan County foster homes.
So that's up from, I think I had statistics in 2011.
Yeah.
We had
And there's been a
23.
concentrated effort to return children from institutions. I think we have fewer children in institutions than we've had in the past. But still, the therapeutic level of care with the private providers, there's still a great number in that level.
Okay, I was just wondering that particular person that's working as the home finder, can you get, a summary of the direction that they're taking,
We have
that
a
maybe?
plan that we submit to the state, and I'll provide the plan to the legislature,
Okay.
the foster care recruitment plan.
Okay, thank you. Okay, any questions for Cora?
Can you explain sort of in a layman's kind of way, what, are the indicators in which a child would have to stay in an institution? In other words, even if there was a foster home and they were equipped and they were trained, they still have to be in an institution for one reason or another? I mean,
It's typically a child who's going to require professional staff, paid staff with 24-hour supervision. So if you go to a residential facility, typically a residential facility, the school component is on campus,
Okay.
right? So from the time they wake up in the cottage or dorm that they live in, there is childcare staff who are there 24 hours a day. So when they go to sleep, there are childcare staff who do bed checks every 15 minutes and are in the hallway. So basically, it's a high level of supervision. When they go to school, they'll walk down the sidewalk to the school. Within the school, there'll be smaller classrooms, a more intensive setting. That's what typically differentiates, is when you can't necessarily live in a community where maybe there's not someone up 24 hours a day.
and the
there.
way that it's determined is through the court system, whether they are there
I mean,
or?
it can be determined by the court if a court orders that they be in a residential setting with that 24-hour supervision itself.
Otherwise, the determination is made
Within the department.
Okay, so then, out of this.
And you may give recommendations also from probation as part of a kind of pre-sentence report.
Okay, so in this chart that you've set up, where would we find the line that relates to the children that
In residential,
that cannot be in
I mean, it's in various lines. You'll be sometimes under that handicapped children school districts. The school districts have an ability to, through their committee on special ed, to make direct placements with a facility, and then the bill comes to DFS. We pay that bill. Under EAF children, depending on the parent's income eligibility at the time of removal.
What does EAF stand for?
Emergency aid to families. It's a federal eligibility category. When kids come in, they're determined to be that federal 4E eligible or not, and that's based on various deprivation factors at the time of removal.
And then, it's all
So
mixed
under
in.
EAF children, EAF tuition is the educational component. Could be under this, would be under the tuition regular, JD Pins maintenance, and that's pretty much it.
Can you explain what JD maintenance means?
JD Pins is the juvenile delinquent or person in need of supervision maintenance, and that would be the room and board or per diem component of that placement.
And then the determination is the same as with the other ones that are in the institutions, whether it's done internally or whether it's done through the court system?
Correct.
I just have
That's helpful, thank you.
one question. When I'm looking at this chart, you're going in the first line from 1/1/13 to 6/30/13.
Right.
And in the one on the right, in 2014, obviously, we can't get out to June because we're not there yet.
Right.
So when I'm looking at numbers, it appears to me that the price has gone down because I divided it by
But each
4,
quarter swings
figuring that
up and
each
down.
one is 4, then I'd have a monthly cost. So is this chart telling me what I think, that the cost has gone down per month?
Overall, the cost has gone down per month. I mean, just sometimes in the quarter, depending on the quarter, still in the first quarter of a year, you may be paying bills from 13. So, you know, some institutions are more contemporaneous when they send their bills than others. There may be a 60, 90, even 120 day lag. So if you're trying to, that's why I think as we go on and you'll see all of the quarters, you'll get a sense of some are more inflated than others because you may be closing bills out for 13 in the first quarter of 14, as an example. And I don't know if I
So like
answered
if
your
I'm
question.
looking at the maintenance regular FC,
Right?
okay, 1093.
No, but actually, that's a 6-month period.
Right,
And
so
then
if I
this is a
divided
quarter.
that, oh, okay, I'm dividing
So that's
Okay.
2 quarters in that first column. So actually, the maintenance regular FC is higher. But that's good because that means there's more kids in that level of care rather than the institutional level in terms of dollars expended.
So they're not going away, they're staying someplace
Right,
local.
they're staying in either therapeutic home with a private provider or a regular foster home.
Okay, thank you.
And the adoption also is a good one, that would be our local share of adoption subsidies to folks who've adopted from the foster care system. There's a federal, state, and local, and I think, and maybe I should correct myself, that may be the entire share, but then there's a breakdown. But you would want to see that increase because then you will see more children who are being adopted.
Okay.
And we're paying, the state is paying a subsidy for the adoption, but there's a local part of that subsidy. And that subsidy can and will be in effect until the child is 21 if they remain in school after the 18th birthday.
So then, if I was going to be the parent, I thought one of the things about adoption was that you no longer got money from the county/state, you adopted.
No, you'll get an adoption subsidy based on the needs of that child, and typically there is a subsidy upon adoption based on child's behavior, based on the length of time the child has been in foster care. But that subsidy is not always, it's typically lower than what your room and board payment was.
Oh, so, okay, so if somebody adopts a child, they get, obviously, the medical and dental and all that, the state pays, correct?
They'll get medical.
And then the family also gets a subsidy?
Right.
Is that go by the income or just,
It goes
Uh,
by the child's age.
okay?
And
Their
then
needs.
the classification of the child in terms of if they're special needs or regular. And then there's a monthly.
Oh, even though they're
rate.
adopted and that's their?
Yes.
So then, I don't know if you can answer, so who claims the child?
They
Fa- the
they
family?
adopt the child, and then that child is part of that family. That child can be added then to
To-
that family's health insurance, plan as an adopted child, can be claimed on
Okay.
income taxes, et cetera, but there still is a subsidy payment.
And they get that till the child's 21 or 18 or?
18, and then if they are in school still, or it can be up to 21, or if they have a handicapping condition.
So roughly, could you give me a number, like $200 a month?
I would
don't-
say more toward 455 a month.
But that would be, depending on what the needs are of the child, like you
Needs of
say,
the
if they
child,
had
age
a
of the
learning
child.
disability or
Right.
physical handicap.
Okay.
This last figure here, at the bottom of the 1/1/14 to 3/31/14, does that reflect the add-ons from what wasn't paid the last quarter?
Yeah, that'll include 13,
Okay.
13 expenditures. there's probably very little 14 in there,
I see.
actually.
This is helpful. Okay, there may be more questions on that.
But I don't know if this is the format you want, or
It's a start, I think. I mean, I don't know how long it took you to put this together, but I remember when we asked for it, we needed to have a baseline somewhere.
okay,
Thank you.
all right.
Thank you.
Thank you. Nancy is not here yet, I don't believe. She's on her way, I understand.
She has a representative here.
I'm Sue.
Oh,
I work
Sue.
as the county's public health educator. She mentioned something to me about coming to talk about the drug task force and what their efforts were, but I don't know if she was still, I think she has a meeting in Albany today.
Well, she was gonna give us the long-term care update,
Okay, so maybe she's still coming then.
but if she asked you to give that piece too, that's fine.
Okay. You want me to do that now? Okay. The drug task force started in, February 2012. Due to the efforts of Carol Ryan, a recently retired health director, there was a comment made at a Rural Health Network meeting that, Boomer from the hospital noticed an increase of our young people coming in that were overdosing on prescription drugs. So Carol invited a lot of key people from the community to come in and talk about this and asked if they would like to, have a task force committee, and they all agreed. So it started in 2012, and we have like, Alan Keston, the county coroner, Jim Farrell, oh, I'm gonna probably miss somebody, but Dr. Sarek from the jail, we have nurses, we have several representatives from the hospital, EMS, Greg Taverino. I would say we have about 15 people on the drug task force. After we did that, we reached out to the schools for a logo design for our committee, and we had a student, high school student, I reached out to all the graphic arts departments and offered the schools, you know, a contest of sort or whatever for the students, and we had a student design a logo, and that logo is now being used on our letterheads and our metal drug drop boxes that are spread around the county. We had the idea for the metal boxes back in 2012, but we didn't have the funding for it, so Carol wrote it into the grant for 2013, and we received the money. And we started researching the boxes and looking for locations, because the boxes have to be located somewhere where there's 24/7 police protection. The first one was accepted by the Fallsburg Police Department. We now have 3 of them in place, Monticello and Liberty Police Departments. I did bring a picture that I'll pass around. We have pictures that have been in the newspapers. The third one will be in shortly, but this was the young high school student. I'll pass it around. Her information is on the back. And we have a 4th box, and we're still presently looking for a location to put that box. And
It
we
wouldn't
use
be at
these
the
bo-
hospital? The hospital wouldn't take it?
we asked.
And they wouldn't take it?
The comment was their lawyers advised against it, so.
It's a security issue.
Right, absolutely. The metal boxes can be secured to the floor, and they are locked.
No comment.
And we use them on the National DEA Take-Back Days also. But at least there's 3 places in the county now where people can take unwanted drugs. We're in the process also of notifying the funeral homes, the county coroners. There's many, many times when people pass away, they don't know what to do with the unwanted drugs and everything, or people have them in their cabinets, like on the DEA day. I had people come in with big bags of them saying, you know, I knew they shouldn't go in the ground, but I didn't know what to do with them. So, you know, they now have a place to dispose of these properly, and our grant funds pay. We increased our take-back days. The DEA does it 2 times a year, spring and fall, and our task force agreed to add an additional 2 days for the county. And we're working with the sheriff's department, and our grant money pays them when we do it on the other 2 months, pays for the officer to pick the drugs up at the locations and take them to the Poughkeepsie Recycling Center there. So, we started the drug drop boxes. We've reached out to senior citizens in 2012, 13 different senior citizen centers. talking about poison prevention and tying that in with safe use of their medications and also safe disposal, and letting them know what they can do with their unwanted prescriptions. We have CDC radio podcasts that are on the air with different radio stations. It could be a little podcast, something about a teenager sneaking into grandma's house with a friend and stealing medicine out of her cabinet. And it tells, grandma now to be careful with her meds. Don't leave them in your main bathroom. Keep them in a safe, secure place. And at the end of the podcast, then we have sponsored by, the Drug Task Force, Public Health, and then there's a little clip. You can now take your drugs to these 3 locations. So we're doing radio advertising to try and let the community know where they can take their pills. We did a presentation last December for the physicians to discuss the epidemic, give them statistics and information to draw attention to the amount of prescriptions that are being written. PowerPoint was done by Dr. Holden from CRMC, and we also had a Suboxone rep come and did a PowerPoint presentation. Suboxone is one of the drugs that's used to help wean people off of prescription pills. We've had Upstate Poison Control Center come to the community, to our county twice. They came, did a presentation at the Recovery Center. We had about 32 professionals that attended. It was entitled New Drugs of Abuse. It was an excellent presentation. And then I believe Joe Todora had them at the Community Services Building for his staff, just for mainly staff, right?
Yeah.
So they've been in twice.
Well, we also invited some of the community folks who had
Community.
missed the first presentation to come in.
Right, and the task force members were invited again. And I'm hoping also that we can get them into the schools, because they will also do school presentations too. So that's kind of like on our list to try and, the task force decided to concentrate their efforts in the first year towards the physicians and nurses and everything. We have a pharmacist that's on our task force also. And then each year, like this year, we're gonna try and draw in the school districts and the students a little bit more. We divided it into like several different groups, and the outreach for each group would be a little bit different for each group of people. We also have the opioid prevention program in the county. Carol introduced this idea in January of 2013, and we had a teleconference at one of our task force meetings, and Dr. Sharon Stancliffe from the Harm Reduction Coalition Center in New York City did the presentation, and the task force decided that this would be a good thing for the county, and the Recovery Center offered to do the paperwork. And it was around July of 2013 that they got the license, and we had our first training in August at the Recovery Center. About 25 Recovery Center staff were there and 2 task force members. This has been a program that's been all around the United States since 2006. There are small kits called Narcan kits, and it's naloxone. Is that how you say it, Joe?
Yes.
Okay. And they were just on ABC News just recently. Mr. Matthews, who did the training from the coalition, comes and he did a PowerPoint presentation, and they pass the kits out. They are in 2 forms, either injectables, little vials of naloxone, or they are now introducing sprays that are nasal sprays, which are a little more expensive. They come in a kit. And it's very similar when you're getting this training to CPR, AED training. You get the training, you have a prescription that's carried around in the bag with you that says that you've gone through the training and everything, and you hope that you never have to use it. But evidence shows that people who do accidentally overdose are usually in the presence of somebody. And a lot of the programs say if there's breath, there's hope, and that you're hoping that you can help reverse the overdose and then try and get them into a recovery center. Or, you call 911 before you use the kits, and if they come around, then you hope to get them into a program or something to help them. A lot of people there's a lot of mixed reviews about this topic. A lot of people have this thought with these kits that it's for junkies. but you have to remember that in this day and age, we have a lot of young people, could be student athletes, that get addicted to pain medication while they're recovering from injuries. We have students that are going to parties, and they're called farm parties, and they're passing pills around and popping pills, and they don't know what they're taking. They all bring pills and throw them in a bowl. It's called trail mix. And this is what Boomer was referring to at the hospital. These young people come in and they don't know what they've taken, so the hospital ER doesn't know how to treat them. So a lot of times there's a lot of accidental poisonings through prescription drugs. Even senior citizens this happens to, because people forget whether they've taken their medication or not.
One of the things that we do know is that when people are overdosing on heroin or those types of substances, it's not that they're poisoned per se, but what happens is that all of their autonomic system shuts down. Your ability to breathe, your heart beating, and all of those things. And what these kits do is they inject a blocker to those receptor sites in your body, so that you will eventually be able to breathe, and you'll also eventually be able to have your heart beat and things like that. And if the person, if they're very early on in this incident, you're able to bring them back. And I can't emphasize what Carol has said enough, or Susan has said enough, that this isn't the classic junkie on the street corner or in an alleyway shooting up. This is professional people who've become addicted to some of oxycodone or whatever it is, and these are people who eventually won't be able to get a script, so it's easier for them to go ahead and get a $6 bag of heroin just across the border in New Jersey, and then they come back and use it. So it's treatable. It's something that we need to, as a community, be more sensitive to, and I thank the Drug Task Force and all its participants for bringing this awareness to it. We have worked with the doctors in terms of thinking about how they're prescribing for pain at this point in time. I think that's making a point, and the state has implemented what's called an I-STOP program. The I-STOP program means that all of these medications get put into a database, a statewide database. So if you're shopping for medications because you're an addict, you'll get caught, because they won't be able to write that script for you again, and the doctor will tell you no. Now the inverse is, you've got an addict and we're cutting off their supply of prescription medication. What are they going to turn to? And that's the issue, and that's the reason why we're seeing the heroin epidemic that we're seeing now.
Yeah, I think that's really good work the task force does. Really quick question. Do they address, because I have gotten inquiries from constituents on the resource piece, and Joe and I met with Mrs. Gomez and Lesha from the youth board. Do they address that to increase awareness and try to form some kind of a clearinghouse where these youth resources are that people can tap into?
Yes, and usually places where we are always constantly, wherever I go, passing out information on. I'll leave things on the desk there if people want to pick them afterwards. There's also the call 911, and there's also a Good Samaritan law that if the person who overdoses or the person that makes the call, somebody calls in, that they will not be prosecuted for making
Well, I
that
guess what I
call.
was looking at, a clearinghouse for, in my Ag and Sustainability Committee today, somebody that does a teaching farm. They have a teaching farm, and they work with kids through BOCES, and we're discussing maybe a summer camp for kids. Is there one clearinghouse where somebody can access somewhere with all the?
If they call Public Health Services, our task force has asked our members, and we're doing outreach to the schools and to communities. We actually would go to one of our members of our task force and ask them if they.
But if a constituent were to ask me as a legislator, where do I go to access a clearinghouse of what's available for my child, whether it be sports programs, or I know Lesha has a good group with the community-based, but there's other ones out there, like the teaching farm, or, is there any place where that information
Are you
is?
talking about specifically with the prescription prescription drug program?
No, I'm talking about, people that are struggling, maybe the youth are struggling, and they've asked, you know, me as a legislator, where to go to access like a clearinghouse of resources that are available to kids. I know information goes to the schools, but it's like for a parent that has a child
Cindy?
that's struggling.
Cindy, if I can address that, we're currently working with the schools on developing a resource list.
Oh, yeah, that's what I
And
was.
we've been working with, Joe in terms of
Okay.
developing a list and pushing that out to the school superintendents.
Okay.
Because they are planning as a group, I've met with them, and they're planning as a group to compile a resource list
And I understand that that's
to get out
fluid
to
because
parents.
it changes and you have to follow up and find out what the capacity is and what area of the county they reach to, but is that something that eventually could be like posted on the county website or something?
Absolutely, and I wanna remind folks that in our community health assessment, there is a very comprehensive community resources list, of a variety of services, not just for, substance abuse prevention, but I also do wanna say that one of the challenges is that we really have limited resources in this county in terms of, prevention services.
Well, that's why the discussion that I was
Yeah.
involved in said, let's look at what we have and let's try to outreach to the areas that maybe aren't served by, you know, certain organizations and try to bridge those gaps. Alan, you had a question.
Question, and then, here I go.
I'm ready.
I'm getting right. I think what we're all missing, what I think from my own observations is one of the reasons our youth are getting into prescription drug problems is the fact that the United States and only one other country in the world allow direct-to-consumer advertising. It's the United States and New Zealand. There are no other countries in the world that allow direct-to-consumer advertising. So I encourage everyone in this room, the next time you're watching TV, CNN, whatever you're watching, you look at every advertisement, not every, but a vast majority of the advertisements are coming from pharmaceutical companies. And those pharmaceutical companies are directly advertising to our children in much the same way that the big tobacco companies advertised cigarettes to our children in the 70s. Unless we address that issue, which is going to be very difficult for the big-time politicians who are funded in large part by these, but they need to stop taking those donations from the big pharmaceutical companies, and they need to repeal the legislation that allows direct-to-consumer advertising. It only passed in 1997. That's when the authorization came through to allow direct-to-consumer advertising for pharmaceutical companies, and look at the results since. You have a major nationwide prescription drug abuse problem. It's not only affecting our children, it's affecting adults, and that, in my mind, is the core reason that this epidemic exists. They not only are advertising to our children, they give them a list of what the symptoms are. So if you feel A, B, C, D symptom, go and see your doctor and tell them these are the symptoms that you have. So they're going in and they're just reading what they hear on TV, and the doctor's writing them a script. That is the root of the problem. I think we got to tackle it. I don't know where to begin. I know I said last month I'm going to pursue this issue. I'd like to maybe even start with a resolution here at the legislative level, asking the state to, or congressman, whoever it is, to repeal the direct-to-consumer advertising legislation that allows it at the national level. And I think I'm going to keep coming back, and I'm going to keep tackling this issue. I'll do my view. I don't know where to begin with this, but to me, that is the root of the problem.
Well, I just want to address kind of the pharmaceutical companies. On the county level itself, that's within our scope, and pharmaceutical companies coming in, is there some kind of a policy that can be set county, you know, I know that they come in, right, and they advocate for their medications, and I'm working with, you know, Josh and several to do a pharmaceutical formulary on the county level, so that the doctors will look at the preferred list. It's not dictating what they can prescribe, but it's a preferred list of generics, because the prices fluctuate so greatly. You could have a pill for 30 pills for $1,000 a month, or 30 pills for $10 a month. So I think, I agree with Alan, I think the pharmaceutical companies are allowed too much you know, leeway. Is that something that we could do, Joe?
Well, one of the strategies that we'll be rolling out through the task force, as well as, and actually we're kind of copying something that's come out of New York City's Department of Health, is really working with docs, GPs, and the pain specialists with regard to certain methodologies that you could attempt to use to control pain instead of just giving a pill. And I think that, you know, part of the issue, as Alan's saying, is that you have the big pharma coming in and saying, oh, here's all the wonderful things that you can get, you know, and some of the GPs, they just want to take care of the person in their community, and they don't realize that oxycodone is one of the most addictive substances you could possibly prescribe to somebody. So don't give that to somebody who just has the flu, you know, because sometimes you're shooting a fly with an elephant gun. So that's one of the things that we're looking to do. It is a national issue because it's the federal legislation that has allowed Big Pharma to do the things that they're doing. And oh, by the way, you have to be very careful about some of the medical literature that you read, because Big Pharma sponsors some of the medical literature.
Is it some kind of, you know, like catch-22 when the pharmaceutical companies come in and kind of market to the physicians? How do we address that whole piece?
They're not really allowed to just directly market to a physician, but because they've kind of changed that a little bit. But they are able to come in and say, you know, here are some studies that we've found that, you know, the use of this medication for these symptoms has been efficacious, or whatever that you want to say. They're no longer able to you know, provide gifts to companies or. Well, they can't do that unless they're doing a educational symposium around that.
Yeah, suppose it is service
Yeah.
or something, right?
But, yeah,
I think we
but
should
it's.
address that piece. Okay, Kathy had a question, and then Laura.
I just have a question.
Never mind, Alan said, never mind.
Okay, I know we're running
I know,
behind
we all
time,
said it,
so.
wait,
Well,
much
Annie
more.
just left the room, but, there's a state sort of taking a circuit rider, on the road, meeting. I think Bonasek is gonna be here.
It's the Joint Committee
It's
on
May,
the Heroin Task
What
Force.
did you say, Josh, May 9th?
Yeah.
2 to 4 p.m. here at the Government Center in the Legislative Big Room.
What's it called?
It's the Heroin Task Force.
Senate Task Force on Heroin.
Senator Bonasek will be here addressing the legislature and the public.
So isn't this a time to bring up these,
As a matter of fact, the Senate has proposed several bills just recently, I think the beginning of this week, to address some of the heroin task force findings so far. One of them is about the use of the Narcan and allowing that to be carried in every EMT and ambulance corps. The other is talking about requiring insurance companies, and this is one of the bigger issues that we run into. A lot of times insurance.
Try to make it.
Okay, a lot of times insurance companies deny access to a 30 to 60-day inpatient program, which many of these addicts need. And instead, they want them to fail on an outpatient basis. And a lot of times, they never make it to the failure because they end up dead. So what they're doing is they're really trying to force the hand of the insurance companies also.
so we can bring that up on the May 9th.
Right.
Yes.
Okay, thank you. We're gonna move ahead. Karen Matthews would like to announce, oh, Nancy, I'm sorry. Long-term care update, Nancy McGraw.
Yes, just a
Thank
brief
you, Karen.
update. We are undergoing a lot of changes in our long-term home health care program because of the state's Medicaid redesign initiative. And basically, our long-term care program has gone managed care, I guess, to put it briefly. And what that means for us is that we will no longer be authorizing services through our program. The managed care companies will be doing that for us, for our patients. Our patients will be receiving letters, have been receiving letters as of this week and rolling forward over the next few weeks from the state, telling them that they need to pick a managed long-term care plan. Basically, it's you need to pick an insurance company to cover the services that are provided. We have 3 insurance companies through long-term care in our county who are going to be coordinating this. And of those 3, we have developed contracts with 2 of those. The third one, we're working on. They don't seem to really be serving Sullivan County, yet. They're supposed to be on paper, but, we're working on that. So, what this means is that rather than a patient, receiving an array of nursing, physical therapy, occupational therapy, social work, home health aid, personal care aid, the insurance company will decide through an assessment what they are eligible to receive.
And the county still pays?
And we will get paid for, if we're developing contracts, and the services that the insurance company authorizes, we will then get the referral for the patients, and we will go out and provide those services and get paid for those services.
So is the thought that somebody in the long-term care program impacted by that will receive less services?
It's a very real possibility, and we're watching it very closely. Our existing patients, our nurses have gone out and provided some education and some information to them to help them navigate through the system. We're working with the Office for Aging in terms of helping people understand what this means for them. Some people will become ineligible for services. We're very concerned because there's a possibility that if they become ineligible, that they may then become a higher risk, and they may end up having to go into a nursing home, which is what we wanted to prevent in the first place.
Because the long-term
So-
care program, I'm familiar with it, really excellent program, because that's what it is, providing services in the home so they can stay home with
Right.
family input and,
Right.
instead of the nursing home, so.
Right. We're hoping that the managed care companies will continue to provide the level of services that our residents have grown accustomed to, that they need to continue supporting them to live in the home. But we're watching it very closely to see what actually happens. Our census has decreased by about 20 patients already, so we're down to about 63.
So where those 20 went to those other,
Well,
providers?
We're trying to follow that very closely. Some of them have passed away, some of them have gone into a nursing home. Some of them just became ineligible for services, but they're okay, they're still in their homes.
Any questions for Nancy?
I'm confused.
So
Are you
am I.
talking about, yeah, I mean, is this managed care for seniors versus Medicare? Are they encouraged to
These-
switch, and
these are-
that's what's coming about?
These are folks that are eligible for Medicaid, low-income folks.
Okay.
And there is what's called dually eligible, which means they may have Medicaid and Medicare, or Medicaid and another insurance plan. And those folks are also being sort of kicked out of the program.
Kicked out of the Medicaid, strict Medicaid, and encouraged into some form of an HMO, okay?
Right, managed care, right. However, the positive side of this is if they continue to need skilled nursing, we still have our certified home health agency, we still have our CHOP. So if they continue to need personal care, home health aid services, and they have a nursing care need, we can still serve them
But it was,
if they
it
have
would be
Medicare.
more limited, because the long-term care program, they can do gaps of time, like 4 hours, 6 hours, right in the home, and the visiting nurse would be a shorter visit.
Well, that's going to be dictated by the managed care companies.
Okay, any other questions?
Is that different than what happens on the Medicaid end of the young people? I mean, the women who qualify for Medicaid and they're encouraged to go through the HMOs for their prenatal care. I know what that goes on with that level.
Yeah, everybody.
Similar to that?
The whole Medicaid redesign task is to push everybody in Medicaid into an HMO style of services. There's no straight Medicaid anymore, or there will be no straight Medicaid.
Right.
Okay, thank you, Nancy. Karen would like to, I asked her to come.
I paid.
And announce her event that we are, so appreciative to the retired senior volunteers.
Careful, I know you know where I live.
Someday when you need
RSVP services, she'll be there
We'll be
remembering
getting
this
them.
moment.
I'm just gonna put out very quickly, the RSVP luncheon is coming up May 12th, would you hush? Coming up May 12th, we know that pretty much all the legislatures except for one at this moment is not attending because he has
Some
other
people have to work.
priorities. But, we have a very good attendance, we're gonna look at about 250, maybe 275 people, which is really good for this year. We tried something new, which was our advertising campaign, which I think went very well. It's all going to go into a booklet similar to this is what we usually hand out. But it's gonna be a lot bigger and thicker this year and more profitable because people have been buying advertising, which is wonderful. So that will hopefully be a keeper. And I think really other than that, if you haven't signed up for the luncheon, please do. Anybody can attend. It's a good opportunity to meet the county. It's a good opportunity to meet the supervisors. We will be having, I think Bonasek may stop by. I think Chris Gibson is coming. Aileen Gunther is sending somebody. So a lot of people will be there. It's a good opportunity to talk to people and to see what they have to say and to listen. So please come. The advertising is still out there. We're still accepting until the 5th. And we will be putting out a wonderful booklet, which hopefully people will be able to hang on to for a while and keep, and it's good advertising throughout the year. So that's it. Thank you.
I won't be there, but you can read my ad.
Okay, we're gonna move ahead swiftly to discussion, integration of welfare to work. Welfare to work, we had the discussion several months ago about integrating the program into Liberty, into the social service arena over there. And what our county code says, there shall be a Center for Workforce Development as a department within the Division of Health and Family Services. So we had met with Laura, where's Laura? And she was gonna come up with a plan several months ago to try and work so that there's a presence of welfare to work in family services. And the way it would work is when an individual comes into the department for benefits, there would also be a transition right over to welfare to work. And, you know, it's kind of been my goal to see that happen because I've gotten calls from constituents that right now, they go to Liberty and get their benefit, they have to make an appointment, sometimes it's delayed for whatever reason, and they kind of fall through the cracks, or, you know, it's not followed through on. So my goal is to see work activities through the Welfare to Work program ready, you know, for individuals when they come in quickly, within a 24-hour period or so, so that they can, you know, there's gonna be a message change that when you come in for benefits, we're gonna try to, you know, provide resources in the job market for you. So I'll hand it over to Laura, because she was gonna give us a little background.
Well, really where it stands right now is we had a meeting the other day, Cindy, Scott, Josh, and myself, and kind of go over that as well as some other things.
Oh, Laura,
Yes.
could you sit at the table maybe, or just stand up? Annie says it's not picking up.
Oh, okay, I'll stand this way. Before I start, I just wanted to take one moment and introduce, especially to the legislators, Alex Rokicki from Monticello Central School. He's a member of the Academy of Finance class, and he's shadowing Annie today.
Oh, nice.
So, welcome, Alex.
How come he's not sitting behind you?
The meeting that we had the other day, started about this, and then Scott had, made the, request to me, that at the executive committee on the 15th, that actually what I need to do is to provide all of you an overview of the entire workforce system as a whole, of all the programs that we do, kind of how we're structured, the 2 tracks that we operate on, both for job seekers and for the business community, especially in light of not just the welfare to work program, but also the casinos and everything else that is going on. So that's kind of where I'm at right now, is now gonna look to start getting ready to do that presentation.
That's when?
That'll be the executive of this month.
This month?
Yes.
Oh, okay.
But Laura, you will provide the plan to
Give it
integrate.
to you.
Okay, so we're working on that goal, possibly a resolution forthcoming. No, in Scott's executive, Laura's gonna give the plan and give the background. Okay, are there any questions about welfare to work?
I'll hold them till we get.
Okay, then we can move on. Okay, to our resolutions, Department of Community Services.
First resolution is
We need a motion.
Okay.
Okay, motion to discuss?
Jonathan Court.
I'm not on this committee.
Second.
Okay, this resolution is to amend one that we passed last month. It seems that the state doesn't want to restrict their contract to a 3-year term. They said it's a 5-year term, or you forego the federal salary sharing money that you have in your budget right now. So that's what this resolution does. It just extends it from a 3 to a 5-year contract.
No cost to the county, okay? Any questions? All in favor? Any opposed? Okay, number 2, to enter into a contract with Adelphi University to allow students to participate in a federal work-study program.
Move it.
Kathy, second Jonathan.
So this is an opportunity for us to have social work masters of level students to come in, not only work in our department and hopefully we can recruit them once they're done with getting their master's degree, but also for them to get paid by Adelphi.
So social work internship?
Correct.
Are there any questions?
How did we get Adelphi involved? I mean, that's a school on Long Island.
Yeah, but we've had a relationship, the department has had a relationship with Adelphi right along, because some of their students actually are from our area. And so we've done student liaison work before with them. This is a grant opportunity that came to them, and they would like to have us as a site where they can have paid interns.
Great.
Is there some way to pull in, like, I know SUNY's community college, but is there some way to pull in SUNY students, maybe to shadow that piece?
They have a program.
Yeah, I think we could
They
look
don't
at
have that
that, but I'm
program.
not sure.
I know SUNY provides students for internships, just a thought. Okay, all in favor? Any opposed?
5-0.
Okay, number 3, to enter into an agreement with Hudson River Healthcare to provide health home services.
Move it.
Kathy, second Kitty.
Discussion?
The health home services are all, once again, part of the state's Medicaid redesign team allocation. What's going on is we provide case management services, intensive case management, as well as supportive case management services to people with serious mental illness. Under the Medicaid redesign and under the state's Medicaid plan, with the Affordable Care Act, you have the ability to develop a health home. Health homes are not necessarily a brick and mortar entity, but are an affiliation of a number of health and behavioral health service providers to be able to take care of those people who are identified as high need, high spend applicants. If we want to continue to provide case management services, which we do at this point, then we need to have these affiliate contracts with the health homes in our area so that we would continue to receive funding for the case management services that we provide. The money that you see there, that is the other line that we'll have to pay out. The revenue that we receive billing Medicaid for the case management services, when it comes in, we will then pay out a per person fee to the health homes that are providing us with some of the administrative capability to do that. So it's this resolution and the next one to follow that would allow us to set up the contractual relationship to be able to, for us to continue to receive revenue and for us to be able to in turn pay them for their administrative support.
That's 26,000 that's reimbursed, right?
We get the money first and we reimburse them the 26,000.
Okay.
All
Any
right, so,
questions?
yeah,
Just keep it.
what happens, so then we're a pass-through of the money is what it amounts to? What happens if the program fails? Do we end up then having to foot that bill?
No, what we're looking at, Kitty, is that as we're providing the care management services, and it's going on right now, but right now there's a direct pipeline between us and the payer, Computer Science Corporation. So as we're doing that, we're receiving the health home money directly to us, but this will allow us to cut a check to the health home for their providing us with a list of people who would be able to you know, we would want to pick up for care management services as well as for them monitoring the overall health outcomes for the people who are participating. Should we decide not to do care management in the future, you know, we would alert them, and based upon our contractual obligations, give them 30-day notice and clean up whatever's owed and whatever's due at that point in time. But we could end the contract.
Without a punishment, a financial punishment, we could
No,
end the
we would,
contract.
we would just have to close the books as, in terms of doing business as usual. There's no penalty for us to withdraw.
Okay.
Okay, all in favor? Any opposed?
5-0.
Okay, number 4, to enter into a contract with Open Door Family Medical Center, also known as Hudson Valley Care Coalition, to provide home health services.
Move it.
Kathy.
Any discussion?
Second Kitty.
All in favor? Any opposed?
5-0.
Okay, and we have a resolution through the Youth Bureau to approve allocation of county funds to youth programs.
Move it.
Kathy. Second Kitty.
Les, are these the same amounts as last year? No.
Extra 10,000.
It is the same amount of $27,600. But what it is, the allocations have been broken down differently. Last year for the $27,600, we funded only 2 programs. We funded the YMCA, at $17,600, and we funded the Obeas anti-bullying program. I believe it was about 5,000 or so. But unfortunately, the Obeas anti-bullying program will not happen this year.
Marcia, can you speak a little louder?
Sure. Unfortunately, the Obeas anti-bullying program will not happen this year. The Cures Coalition will not be able to provide that service in the schools.
But a lot of the school districts are doing their own anyway, and I know right?
Some of the school
Right.
districts are already doing it because the Cures Coalition over the last 2-3 years has trained the teachers and the staff to provide the program, and the staff was able to take over that responsibility. So some of the schools have been trained in the Obeas bullying prevention program, and they're currently having that up and running.
And I believe the Lions clubs also do that.
Yes, they do. Yep.
Okay, any other questions?
Yes.
Dee?
Looking at the breakdown of the funds, I definitely believe the YMCA is a worthwhile organization. That's not where I'm coming from. I'm coming from, most of these things are 1,000 or 1,500 or 750. Is it the YMCA getting 17,600? Are they planning on serving more youth than the other groups? I mean, why are they getting it so much, or is that more than they had gotten in the past?
The YMCA received $17,600 last year, and they served 2,096 youth in 2013.
Sullivan County youth?
Yes,
2,000?
all the youth were Sullivan County youth. If you look at some of the towns, they also serve large amounts of youth, but not quite as high as the YMCA. The town of Bethel served 135 youth in 2013, town of Coshocton 102, town of Walsburg 201.
So it's more like the amount, 2,000 versus 100.
But Lesher, is it based on how many they're gonna serve this year or how many they served last year? Because I'm curious, because, and I'll have to call my supervisor, if you're giving the town of Mammoth $750 and their population is 13,000, why would Lumberland be getting 1,000 and has just a small population? How is that based?
Right. What it is currently we receive funding from OCFS. All the towns are still gonna be receiving their OCFS funding.
Okay.
What I requested in the 2014 budget was for some of the, knowing that Obeas will not be happening, for some of the Sullivan County funds to be allocated to the towns as well. So if this resolution passes, the towns will get money from the state that they're currently receiving, plus they're gonna receive the extra funding in this resolution.
Okay, thank you.
So they're gonna get a little extra, which I really feel they deserve because they do serve a lot of kids and their programs are excellent, they're high quality, they're located throughout the entire county, they're not just in Monticello or in Liberty. Like for example, they're in Highland, Lumberland.
Lasha, can I just ask a
the
question?
outskirts.
You have all the programs and everything, and you're working with them, and you know the capacity and the areas that they serve. Is it possible to get like a map of where these organizations serve so that we can fill in the gaps? Because over by me in Western Sullivan, you know, people ask me, you know, is this group here, is that group there? I don't know,
The
so.
thing is, I could provide you with a list. For example, the town of Mamakating accepts children into their programs from all around the county. Whereas
Okay,
the
that's what
town
we need
of
to know.
Lumberland only accepts
From
kids
Lumberland,
from the
correct.
town of Lumberland. So I could get you a list of the programs.
Yeah, if
the
we could
town-
just understand the reach of these programs that, you know, are serving 2,000 kids, to find out if they're in certain
Right.
regions or not, and then we could work maybe to pull them in.
Right, like, for example, the YMCA, they'll take children from the entire county.
Okay, so, yeah,
So
if you
some
could get us a
programs
piece for next
serve-
month, would that work?
Oh, yeah, sure.
Yeah, okay.
I could provide you with a list,
Okay.
definitely. And, the one new program that you'll see on the resolution is the first one listed, the Sullivan County Soapbox Derby. I'm very excited about funding them. Their program is run in Liberty, but they take children from, the entire Sullivan County to participate in the program.
Is that why Liberty's not listed separately? Because the money
Liberty-
goes to that?
Liberty has a Parks and Rec department, and they chose, not to be funded by the EPO.
Okay.
They feel basically that, in the past, they felt that, it was a lot of work with the grant application and the paperwork, so they chose to not be funded for that time.
Okay, any other questions? Okay, all in favor? Any opposed?
5-0.
Okay, were there any other reports? Okay, public comment?
Public comment.
Priscilla?
First of all, I want to say that there's going to be a grassroots senior day on Tuesday, May 20th, sponsored by statewide Senior Action Council, of which SLAC it has been forever, even in its earliest days, an affiliate. So we are participating in that. We'll be leaving from the government center on about 8 o'clock, or from Woodburn at 8:15. This has my number on it rather than the